I think you're muted, Dave.
Nope, you're good to go. It's the recording started, so
Oh, good to go. Okay,
you want to
super.
start?
Okay,
Yeah.
okay, super. Okay, super good. Well, welcome everyone, and so excited to see each one of you here. And it's one good thing about the Zoom meetings. We have visitors from around the globe joining us this evening. So, or whatever time of day it is for you. Welcome to the MacGLObAS 2021 Fall Seminar. My name is Jean Chamberlain. I'm one of the members of the group, and just really excited that each one of you have taken time to join us this evening. We've got some really good, interesting discussions coming up, and some times for discussion and just brainstorming. So we want to thank you for taking the time to be part of this group. The subject this evening is, as you know, is recharging global surgical partnerships post-COVID. And I don't know if you can just see, those of you who have your video on of some sort, there's a raging storm behind me there. And there's, it's a beautiful picture of sort of the forces of nature, and lots of color and lots of energy. But we always know that when there's a storm on, there's also lots of challenges as well to safety and security, and just still avoiding danger, but at the same time progressing. And so I think as we look at this issue of recharging global surgical partnerships after COVID, maybe that picture is a good one to have in our minds, that there's still beauty, there's still opportunity, but we have to be strategic so we're not getting swept away in the storm, and some of those things that we've worked so hard at for so long can sometimes be lost. We want to keep that in mind. As we know, there's always challenges with surgical partnerships globally anyways, let alone in a time like this. So COVID's made us all think differently. Here we are on a Zoom meeting tonight, and we're so happy that Dr. Harvey can be with us here. And maybe if we had had this at the Faculty Club at McMaster, she may not have been able to make it. So lots of good things can come out of new ways of thinking. But it does take some intentionality, and always good to hear different people's perspectives too. So whether you're a student, whether you're a faculty member, wherever you are on the continuum, clinician, an academic, welcome. And we know we all have something to contribute tonight. Just a little bit of housekeeping, just a reminder that when David, who we're so grateful for David for his incredible leadership and assistance with this evening, as well as the whole MacGLObAS program. He's literally surviving COVID right now, and so we're so thankful for him that he was still able to just do such a great job of organizing this tonight. So big, huge shout out to Dave. So everybody get in the chat there and give Dave a big wave there if you don't mind. But anyways, Dave reminds us that when he puts on the video of somebody speaking, if people can please take off your video and mute yourself as well too, just that will help as well too for the videos to run a little bit better. I think a really important and exciting part of tonight is the breakout sessions. We're going to have 3 different groups, probably depends on the numbers. And there's going to be discussion around that too. I think you've received some questions about that. But we will look forward to those group discussions as well too. So, the group 3 is Joel and Dr. Harvey. Group 2 is Lori Ellett and Jacqueline, and then group 1 is myself with Mike Kagawa. So thanks to all of you that are willing to help with those breakout groups as well too. And then we'll come back and chat about it as well too. So that is coming up. We'll have 2 breakout sessions, and we're going to be really tight with the time. It's one thing I've learned about David. He's an on-time man. So when the time's over, he's going to break up the breakup group. So make sure that you stick with those times. Okay. With no further ado, I think we're going to move into the presentations. We have 3 fantastic people speaking this evening. We have Dr. Lori Ellett. These are pre-recorded sessions just to help with timing, et cetera. But Dr. Lori Ellett, who, as you already heard, if you joined a minute earlier, is on the plane to Cameroon tomorrow. Dr. Okong from Uganda, and then Dr. Harvey from Guyana. So we're going to hear from all 3 of those speakers, and each one of them are going to be introduced by various people. So I'm going to turn it over to Jacqueline. Jacqueline has her Master's in Global Health here from McMaster, and is very engaged in global health issues. And we're just really excited that you're part of this tonight, Jacqueline. So over to you to introduce Dr. Ellett. Thanks very much.
Dr. Ellett is a gynecologic oncologist and professor emeritus, previously full-time faculty in OBGYN at McMaster University. She recently left full-time practice, completing a diploma of tropical medicine at the London School of Tropical Medicine and Hygiene, and to contribute to the unmet global surgical needs in low-resource settings. She is an expert in global health and has clinical experiences as an educator, clinician, and administrator in many countries, including Papua New Guinea, Haiti, Bangladesh, Pakistan, Mongolia, Macedonia, and Cameroon. Thank you, Dr. Ellett, for sharing your expertise with us this evening.
Today's seminar is about re-engaging global surgery partnerships after COVID. Who am I? My name is Lori Ellett. I'm a GYN oncologist who decided to leave my position at McMaster in Hamilton Health Sciences in September of 2020. And my goal is to spend 5 years that's remaining in my career in low resource countries like Cameroon. What I've accomplished to date is I did a diploma in tropical medicine at the London School of Hygiene in the late 2020. I was at Mabingo Hospital in Northwest Cameroon for the first 4 months of the year. I was recruited back to Newfoundland because of some staffing issues for the summer, and I head back to Mabingo on November 19th of this year through till the middle of next year. What I'm hoping to accomplish in this next 20 minutes or so is to give a definition to global surgery, discuss why we need partnerships and what happened during COVID and where we're at now. And the bottom graph kind of shows you those same objectives and the timelines that are involved. The definition of global surgery on the right-hand side is academic scholarly training and care provision relationships between high income and low middle income countries. Grant has described it in these 4 circles where clinical care is the big component of our activity, but global surgery also involves the education and exchange of trainees, importance of research monitoring and evaluation, and the importance of engaging in collaborations and partnerships. Pre-COVID, we know that surgical diseases accounted for 1/3 of the burden of diseases, and that globally 9 out of 10 people lacked access to basic surgical care. They were unable to afford it, the care wasn't safe, and the care wasn't timely. Why was this so? Well, it was impractical for many patients to travel to medical services, and there was also a shortage in healthcare personnel or physical resources. It's estimated that there's over 1 million numbers shortage in specialty surgeons, anesthesiologists, and obstetricians. Not only is there a lack of access, but access is linked to quality, and quality means that there's poor or inadequate training of the people that are currently in the workforce. There may be no assessment in training, and there's no quality control after training is completed. In fact, during my time at Mbingo in Cameroon, we had a surgeon trained from Togo come, and he had never actually seen or done a hysterectomy in his OBGYN training. He was in a government hospital, and the hysterectomy cases were moved to private hospitals where the physician could get a higher dollar value. And so the trainees had never done any kind of ovarian surgery or hysterectomies. And yet he was now a bona fide obstetrician gynecologist. So pre-COVID, we know that 75% of the world's population had access to less than 25% of the surgical procedures. And part of this, like I mentioned, was a paucity of surgeons. You can see the relationship of the number of surgeons in Canada to the CAR. The UN tried to meet this problem by implementing in their Sustainable Development Goals number 3.8, which suggests that there should be universal health coverage for all the point of surgery should not be to deplete everybody's resources. The Lancet Commission on Global Surgery developed a framework, and we're going to talk about that a little bit later, with recommendations, indications, and targets to try and improve access to surgery. But a big part of this is partnerships and the importance of comprehensive care and sustainable care, and how partnerships can get us to that point. So during COVID, we found that in the high-income countries, when there were needs for personnel in ICUs or emergency rooms, surgeries stopped to divert those resources in personnel as well as in PPE to the places where it was immediately needed. We had stay-at-home orders, which led to social isolation and restriction of mobility. And this limited travel for a lot of the high-income staff who were in partnerships with low-income settings. And it not only decreased their ability to be present in person, but it also decreased the presence of the resources that were brought with them. So in essence, clinical care and delivery still happened in low resource settings, but a lot of the other factors were suddenly stopped. What happened post-COVID in the low-income countries? Well, before COVID, they still had to pay for healthcare, and post-COVID, patients still have to pay for healthcare. Pre-COVID, the social determinants of health were as they were, and now post-COVID, it's no different. In fact, it may actually be worse. And in areas where there were conflict, there still is conflict. This is the hospital that I work at in Mbingo, and you can see that the ability to social isolate or social distance is not present. In this hospital, patient families have to bring food, so you can't restrict families from access to the patients. Access to testing, either rapid testing or PCR, is really limited, so patients are admitted and go to the OR without those kind of testing options available. Even though we may be in a better scenario in high-income countries where more of our population is vaccinated, that opportunity is not existent at the moment in many low resource settings. What COVID showed us is not only in high-income countries, but also in low-income countries, that there are very deep cracks in the health system, and it's really important to try and build sustainable systems, not only in our high-income setting, but also in the low-income situation. What have we found during COVID? Well, having fewer resources in low-income settings did not stop development, but it actually stimulated innovation for novel ways of trying to develop PPE or ventilators. But it really showed that instead of high-income countries coming with their solutions to what they think are the problems in low resource settings, it's really the low income and low middle income settings that have to frame their problems and identify solutions and bring partners alongside. Those partners may have systems already in place that can help, or they may be part of creating systems together with the low middle income settings. So in the Lancet Commission on Global Surgery, there were 6 domains that still need to be worked through. COVID didn't change these domains. They still exist, and they still need to be uptaken and navigated. And I'm going to touch on a couple of them in the next few minutes. So whatever solutions are identified, they really need to be sustainable. In terms of workforce, the development of surgeons, one of the outstanding successes in 2008 was the Royal College of Surgeons collaborating with COSEXA in Africa to rewrite the surgical curriculum develop objective standards for examination, and develop standards for membership and post-membership e-learning platforms. Not only do you have to train surgeons, but you need to train the services that work along with surgeons to do the job, like anesthesia and nursing. And there's a lovely example from Rwanda where the Human Resources for Health programming worked on a project plan to develop anesthesia and nurses. And they did this alongside 22 US academic institutions. Not only are they working in surgery, but they have moved on to include orthopedics, OBGYN, and neurosurgery. And it's really stepped up the quality of nursing care, not only generally on the ward, but with specialization in perioperative care. Task shifting is another opportunity for partnerships. So you may not be able to have an anesthesiologist, but you could have a non-physician anesthetic provider or a non-physician clinician help either on the surgery side or on the anesthesia side. And there is a lovely partnership for Surge Africa, which is trying to develop this mentorship program to strengthen teamwork, promote task sharing, and improve overall surgical capacity in the hospitals. The difficulty with programs is there needs to be some sort of not just standardized training, but standardized licensing and post-licensing evaluation and update. And that's a big gap that will need to require a lot of effort going forward. In terms of education, it's really important that the education is African or low resource country centered. It's great to want to bring laparoscopic skills in, but in Africa, the issue is a huge number of operations that need to be done quickly, safely, with few complications. And laparoscopy requires a lot of equipment, a lot of training, and may not meet the needs of the population at the time. So there needs to be a lot of planning about how that process gets implemented. Information management has been a big aha in high-income countries during COVID, but it is also a resource that has been developed in the low-middle-income countries. It can involve patient-provider visits, but that's usually by telephone as opposed to by Zoom. One of the things that we had great luck with in Cameroon, Kenya, Belarus was the fact we had linkage with MD Anderson to the echo tumor boards. So we were able to continue to do case reviews on cancer cases or with colposcopy cases on a monthly basis during the whole pandemic. Telepathology and teleradiology is also in our setting. So if a physician was not available, we could download the assessments of pathology to the American pathologists or to other radiologists to help with patient care. I'm going to comment a little bit about education. It does overcome some barriers of educational travel, but it has its limitations as well. I have done some work in Guyana, and I was asked to give rounds in Guyana, and I found it really difficult to do that by Zoom. My presentation was on the big screen in the country, but I couldn't interact with the audience, and I couldn't get a feel for where they were at, whether they were understanding the concepts I was trying to relay, and I found it very difficult. So yes, they got my lecture on germ cell tumors of the ovary, but I'm not sure how much they learned or understood of it because of that lack of feedback. This is in contrast to the training I took in London for the diploma in tropical medicine, where each of us by computer was linked with our class and our educators, so that we were always able to ask questions. And there was a good interaction of feedback, so that was a learning situation. So that is one issue with the Zoom platform. But another issue is the huge cost of broadband in low resource settings. And a homegrown, a low resource solution to this could be that the telemedicine is given free or very low cost opportunity, or that there would be government sponsored network technologies to run these kind of educational or healthcare platforms. But at the moment, it is a resource intense issue in many countries. Surgical simulation is an opportunity for learning if that's already in place before COVID. I know of one center in Africa that did have surgical simulation models, but this may be a way to work forward for high-income centers that have that technology to bring it into low-resource centers now post-COVID. But it is a way of trainees getting to learn tasks and putting in chest tubes, suturing, pig gut, whatever that is, to help skill development. I was one of the physicians that traveled a fair bit during COVID, but I will tell you that travel has very much changed. You always have to know the status of the country you're going to, in terms of how many vaccines do you need, what documentation you need, what COVID testing you need. This all costs money. Different countries, it costs different amounts. If the COVID test happens to come back positive, you need to have plans for isolating in whichever country you're at. You have to be prepared to wear a mask, not only in the airport, but also throughout your flight. And when you go to some low resource countries, social distancing is nothing that they understand. It's activity as usual. And I'll give you an example of this. We had a surgeon from the US who was double vaccinated with Pfizer. And that person was supposed to go back to the US a couple of days before I was supposed to go back to Canada. And she had a COVID test thinking it would be negative, and it was positive. And a day or two later, she has another COVID test and it's still positive. And it wasn't until a few days later that we both went for a COVID test that luckily I was negative and she was negative, so we could head back on our respective flights to North America. So the vaccine does prevent severe disease, but it doesn't mean that you won't be pollinated with virus from the activity that you've been doing in the country that you are a guest. In terms of governance, which is another of the Lancet objectives, there is a move to try and develop national surgical, obstetrical, and anesthetic plans that preceded COVID. Only 6 countries globally have completed these. Some of the other countries are formulating them, and some have expressed interest. Being in the cancer world, I very much appreciate the impact that plans have in getting national ministries of health or national educational bodies on board to move forward an agenda. So in terms of partnership, being at the table to help facilitate the development of these plans would be a really outstanding place for partnerships between high and low middle income country collaboration. And I just have to mention that last week, the Minister of Health from Guyana was here in Hamilton, and he has signed a memorandum of understanding with McMaster University to, again, develop the partnership for ongoing relationships in education, clinical care, and training of the different areas related to surgery and anesthesia and OB. And it is an outstanding example of what can move forward when we're kind of on the other side of COVID, and they're probably still in the middle of COVID, but as we move into our no existence with COVID as a fact and not a crisis. So I do have some references, and I'm sure these slides will be available for you to access after the talk. But I'd like to thank you for your attention, and hopefully I've given you some thoughts about where partnerships can occur on an individual, on a discipline, and on a systems basis. Thank you very much.
Thank you, Dr. Ellett, for that illuminating talk. Does anybody have any questions for Dr. Ellett? If not, I guess we can move on to remain on time.
Hello, so we're going to move on now to our first small group discussion. So based on Dr. Ellett's talk, we've shared some questions, as well as an article that's being distributed to everybody who registered. I'm going to manually put everybody in their groups, and then once you're in your groups, the facilitators will guide the discussion for the next 10 minutes. And again, if anybody has any questions for Dr. Ellett or any of the other speakers, feel free to post them. If we're not able to answer the questions, we can always ask the facilitator, or we can ask the speaker to address the questions after the talk also. Okay, so give me 1 second and I will move people into the breakout rooms.
Feel yourself moving.
It will take me 1 moment. Yeah. Okay, everybody should receive an invite now to join their groups.
So David, we moved our breakout room back into the main room, sort of looking at the time.
Hi, everyone. Just give me one moment. I'm going to end all the other groups and bring everybody together, okay? Sorry about the delay. Okay, I think everybody's back now. Dr. Chamberlain, I'll leave it to you.
Super. Okay. Well, great. Thanks very much, everybody. And just a reminder, when Dr. Okong comes on, we'll all unvideo ourselves so that we get broader bandwidth there. So thanks, everybody, for participating with these breakout rooms. And it's good just to hear each other share our different examples, et cetera. So thanks for that. It's our privilege to hear from Dr. Pius Okong in just a moment. Pius is a leading obstetrician gynecologist in Uganda. He is the director of health services in Uganda. And basically what he does, he's responsible for all the health workers that are employed by the government in Uganda. So he has a tremendous responsibility in terms of the human side of medicine there. And I know him as a colleague and as a friend there. He helped start Save the Mothers program that I've been involved with there. And he's the board of the directors there, the chair of the board there. He also teaches at the Uganda Christian University and is a longtime clinician at Nzambia Hospital, and is a real example of a strong leader. He's got his PhD. I mean, he's a very, very well-known OBGYN involved with the Federation of International Gynecologists and Obstetricians. Very, very strong researcher, and it's just our privilege that he took time at this point just to share with us. He's had some personal tragedies himself during COVID. So I really appreciated his willingness to take time a couple of days ago to do this presentation. I really look forward to hearing what he has to say. So without any further ado, we'll listen to Dr. Okong. Unfortunately, it is the middle of the night for him, so he's not on the session today, but we'll move shortly thereafter to hear from Dr. Harvey as well too. So Joel will introduce her. So go ahead and we'll hear Dr. Harvey. Sorry, Dr. Okong. Thank you.
I'm Pius Okong, professor of obstetrics and gynecology, I trained as an obstetrician in Uganda and qualified in 1996. Practicing obstetrics for all those years. Did my doctoral studies in Karolinska International Maternal Health. I have a family and also provided technical support to World Health Organization in terms of research review, especially Department of HRT. Worked as first president of obstetrics and gynecology in Uganda, also for the International Federation of Obstetrics and Gynecology. And I do part-time support research for postgraduate students. Uganda Matters in Uganda. Do supervise postgraduate studies students, especially in Lund University, and doctoral students in Lund and Karolinska University in Sweden. So then when I was asked to talk about this particular topic, I was excited to be part of this, and I hope I'll be able to share with you some of my experiences regarding partnership, especially now that you are in that considered post-COVID. So typical then, when you talk about partnerships, in business partnership, normally in business partners who agree to cooperate to advance their mutual interests. And so when it comes to medical practice of health in general, what would be partnerships in surgical care? So in clinical medicine or surgical practice, partnership therefore would imply the medical practitioners or institutions or organizations involved in who agree to cooperate to advance interests. This could be non-governmental organizations with another governmental organizations, could be universities or universities, training institutions, and so on and so forth. So they are all this kind of partnerships. They have a common agenda, they come together, and when they do come together, they then have terms of reference as to what they are going to do, how to go about doing that. So it's with this in mind then that I would like to then share about some experiences related to international or national. And I will start by looking at the common problem, and that's the psychopathic fistula. Obstetricians, they are probably heard about this, and surgical colleagues as well, they have heard about this fistula, debilitating obstetric fistula, preventable, and yet very prevalent in sub-Saharan. Surgical repair is probably the only remedy, but there's a large medical need, more than 75% in low-income and middle-income countries in sub-Saharan Africa. Surgical repair. So you find then partnerships have occurred in different settings, different countries, and so on. And you find professional societies like Association of Obstetricians in Uganda, you partner with the Rotary. The Rotary Club provides the resources able to meet some of the costs organizing what one would term surgical camp. So in Uganda, Southern Sudan, Ethiopia, and a couple of countries like that, the routine services for repair of the fistula is not able to cover all the cases that need repair. So the professional societies or particular hospitals will then organize campaign for information dissemination to the community that will have experienced problems with urine come to a particular hospital at particular time, and there'll be doctors available to screen them and detect those who need surgical help. And in this kind of arrangements, they call them surgical camps. Often then you find hundreds of women come for screening, and in one camp then you 700 women who have surgical fistulas or rather certification and so on. So the professional associations and partners with Rotary clubs then bring other experts from within the country, sometimes even from outside the country, to that particular camp for 2 weeks, able to operate on all these research. So in terms of COVID-19, then you realize that this kind of activities have been severely restricted, denying women highly needed care. Similar experiences have been experienced again in Southern Africa, cataract surgery, where again this large unmet need. Professional societies or do organize camps to address the need for cataract surgery. So COVID-19 then limits ability to congregate people together in low-income countries, Uganda in particular, and Sub-Saharan Africa. Put people together at a time like this risks spreading COVID-19 because less than 3% of the population is vaccinated. So even if movements are being restrictions of movement are being lifted, it's really difficult to get people to come together. So partnership between Association of Obs and Gyne and Society of Obstetricians and Gynecologists of Canada, when I look back, then I see the success of such an organization where the two societies came together and developed a concept of scaling up emergency obstetric care. And we had then funds which we availed to the two societies. And we had resident obstetricians at the sites in Uganda where we carried out this availability of emergency care. One of our dear friends, Jill Chamberlain, was one of the presidents in a project like this, and she had a life transforming experience of living in a district and providing emergency care. And the lessons learned from such interventions where partners came. So the two partners were equal, each one providing technical support to the district at the resident at any particular time. The information that was gathered was then put together, and these lessons were shared, and emergency obstetric care was then scaled up, not only in Uganda, but in many other countries because of the success of the project like that. Secondly, Society of Obs and Gyne of Canada also built capacity locally in Uganda for the local society to deliver alarm calls for emergency obstetric care. COVID-19 did not affect the international partners because the capacity had already been built by the local institutions. But rather, the local capacity to mentor and contribute alarm was affected to some extent because then it was difficult to move, go to particular places to build capacity of midwives and physicians who are practicing. Another example of partnership between universities, I mentioned University in Uganda, where I participate. So they partner in postgraduate training. They offer master's degrees, doctoral degrees in Rome, and students both in Uganda and other countries do participate in these courses in Rome. Ugandan students take part in these courses, postgraduate training. So the teaching faculty, which consists of even those who are not in Sweden, including myself, teach, supervise both masters and students, and also supervise. So COVID-19 then has affected implementation of some aspects of this program, where we received students coming from Lund, and usually they are from other countries who come to Uganda for field experience. That be postponed for obvious reasons. But on the other hand, the other aspects of supervising the students in their research, supervising them in their work has continued using virtual means and other means to be able to keep. And so with COVID-19 challenge, then is the fiscal restriction on movement, because each country has policy on when to allow people to move, not to move, the requirements for vaccination, and so on. We have found that it was feasible to continue online activities such as teaching, monitor the research and mentor the students, publishing, obviously, supervision and examinations. And so, but it required then building the capacity of the teaching faculty, capacity students changed to online mentorship, online teaching, and support, and so on. And that required structured way of building that capacity. Some of the things that are then common in this kind of partnerships are, one, we note that physical movement of partners from one country to another became a challenge with COVID-19, and we have had to adapt and change. The project that I mentioned, Dr. Jim, after the scaling up of emergency care, for example, then the two societies and other partners again, almost called Save the Mothers program, which is an ongoing partnership between mothers in Canada and Save the Mothers in East Africa. And the physical movement and bringing people to experience the provision of medical services to women in the community, curtailed the students from Canada coming to Uganda for that particular exposure. Secondly, when one looks at transfer of knowledge and skills, which is usually required in the same physical environment, this was by COVID-19. Three, physical mentorship, where we are side by side. This was extremely restricted under COVID. We have tried to overcome that using virtual approach. The other factors, of course, are physical transfer of equipment and medicines and supplies. Although this is restricted because of transport challenges, there are no direct flights between countries sometimes. We have used longer routes to be able to transfer. Then sharing of other resources. Then this includes physical transfer of diagnostic tests, so on. But it has been possible to continue research collaboration, for example. And then finally, how to use innovations, use of videos, the use of artificial intelligence. This is work that is still ongoing. We need to figure out how we can continue to do that. Finally, I just want to emphasize, when you think of building capacity of say physicians or health providers and so on, we need to then discuss what's the role of simulators in this context where there are restrictions. What's the role of mannequins, skills labs, robots, not robots, and video. This is an area that is still new to be explored, where much of the work is going to be done online, that virtually. How can we explore this? How can we build databases able to develop artificial intelligence that is relevant in a particular context and so on, so that we're able to continue working in spite of COVID-19 restrictions. So after sharing that, I would like to thank you very much for listening, and I hope you have fruitful discussions that to this international partnership. Thank you for giving me the opportunity to share my experience. Thank you.
All right, well, thank you very much. As Jean mentioned earlier, Dr. Okong is not able to join us because it's the middle of the night where he is right now. But as David indicated in the chat bar over to the right of the screen, if you have any questions for Dr. Okong, please email MacGLObAS@McMaster, and we will share the questions with him. And that's probably true, I would think, for any of our speakers, though. Hopefully at the end of our presentations, we'll have a bit of a broader Q&A session, so give you all a chance to ask your questions. So we're going to move on to our final presentation of the night. And before we do that, I'm just going to introduce Dr. Alexandra Harvey, who's going to be giving us our final presentation. So Dr. Harvey is a consultant anesthesiologist at the Georgetown Public Hospital Corporation in Georgetown, Guyana. She's also the Director of Medical Education at the Institute for Health Science Education. She is the Anesthesia Residency Program Director and is an Assistant Clinical Professor Adjunct in the Department of Anesthesia at McMaster University. She's also a gracious and patient host and has welcomed more than 30 visiting anesthesia volunteers to Guyana in the last 5 years, with all of the logistical hurdles and disruptions to family life that tends to entail. So she's also a very good friend and colleague, and it gives me great pleasure to introduce her this evening.
Good evening, everyone. Thank you for inviting me to present and be part of this forum. In order to tackle this topic, I thought that I'd start by providing some context by looking at how we were in Guyana before COVID in relation to our postgraduate specialist training programs and international partnerships, with an emphasis on the surgical and anesthesia programs. Then I'll look at where we are now with a view to discussing how international partners can support us. Now, when I say a view from Guyana, I really mean my view as Dr. Alexandra Harvey, Director of Medical Education, in charge of postgraduate programs here in Guyana since about 5 years. And when I say Guyana, just to remind you that I mean this place here, the only English-speaking country in South America, a country about the size of the UK, but with only about 2% of the population. I won't even try and compare it to vast Canada. And specifically in Guyana, I mean this location here, the capital Georgetown on the coast. And more specifically, I mean this place here, the Georgetown Public Hospital Corporation, or GPHC, the only tertiary referral hospital in the country, where all our postgraduate programs are conducted in affiliation with our University of Guyana, and where they have kindly given me an office and educational department called the Institute of Health Science Education, or IHSE, somewhere down behind here. So I'm not talking about this Guyana full of jungles, waterfalls, and sweet scenery, according to the words of one of our popular songs. Although this Guyana does exist, and you really can get that close to our famous Kaitio Falls, the world's largest single drop waterfall at 741 feet, 5 times higher than Niagara. And that's the plug I have for my country. Our postgraduate program started in 2006, initially with the 2-year diploma in general surgery, with the help of Dr. Cameron. But by 2019, my index year for before COVID, so 2019 BC, we had 13 programs across various specialties, 6 of which were between surgery, anesthesia, and obstetrics, as highlighted. But by 2019, all of the 2-year diplomas had now been expanded into our 4-year specialist M.Med programs, and general surgery diploma had been phased out. So I just put that in red there. All these programs had a basic need, which is that they required external support from outside of Guyana, some to develop the program, some to start them, to teach in the classroom and clinical areas, and to provide examiners for our final exams, which help lend credibility to our processes, and to help with our research development, as all specialty M.Med graduates are required to complete a scholarly project. We also needed external support for our trainees to get the exposure to experiences and technology not available in Guyana, but which it's required for them to do to achieve the level of competency and skill as specialists. International partnerships provided this support for our basic need. We had in Trinidad, in the Caribbean, in the US, in the UK, and in Canada, where we had partnerships with McMaster, CASIF, CAGS, and a group out of Halifax called Micro Research. So they provided the support by sending volunteers, usually for about 2 weeks at a time, and allowing trainees to do rotations in their centers. We considered ourselves really lucky to have these partnerships, but there were, of course, some challenges with this partnership model. Not to bite the hand that feeds me, but I would say some were expected, like the first 3, related to travel logistics. Once you're having people traveling, you expect that. Finding volunteers, matching appropriate volunteers to the curriculum. Well, these are admin issues we could expect. And obtaining overseas rotations, because we know we're competing with the residents at your centers. But the last 2 in bold were not so much expected. Some of our international partners that came as volunteers would teach, but were a bit evaluation and paperwork shy. And so obtaining written student assessments and external examiner reports from the volunteers sometimes was a bit of a challenge. And the last one, maintaining training standards, balancing volunteer desire to accommodate cultural norms against establishing or maintaining training standards. It's a bit of a mouthful, but let me see if I can give you an example of what I mean. In chatting with a volunteer, especially in the early days, he mentioned that, of course, Dr. Harvey, the residents came late to their shift. And I said, why, of course? He looked a bit surprised, but replied that he had noted how things were done here in Guyana, where persons arrived late for events or to work, and it was no problem. Nobody said and told him anything. And he was actually right. But I had to let him know that even if this was so in our society, it's definitely not acceptable in a training program where we prize professionalism and professional behaviors. So I urged him to do what he knows is correct in terms of admonishing those delinquents and help us to develop better practices and higher standards. But despite these challenges, by the end of 2019, in surgery, anesthesia, and obs and gynae, we had graduated 61 residents over the 13 years since 2006, and we still had 55 residents in training out of the total 134 that we had. But then COVID came. And for us, it was the same day that WHO declared the COVID-19 as a pandemic. It had effects on our training, as in many of us all over the world. For us, it meant that we had no volunteer visits, no volunteers teaching. Some of our international partners actually left us because they had their, obviously, their own problems. And then there was a constantly changing situation. We stopped our programs, then we restarted them. Residents were actually redeployed to other areas. They got ill, faculty got ill, and of course, then their family members they had to look after. So, but in this time, we were able to start back using Zoom. That was our preferred platform. And that really proliferated during this time. So the volunteers from overseas could actually start teaching. But this is obviously in the context of the fear and the fatigue and the exhaustion and mental health challenges posed by COVID. So where are we now? But I want to emphasize that now for us is not post-COVID. Now is a new normal, which is ever changing. So now our basic new normal post-COVID needs are equal to our basic pre-COVID needs, I would say. But our current challenges are not the same. So what are our current challenges? Well, once travel restarts, I guess we will still have our old challenges related to travel logistics and admin issues. And the international partnerships, I believe, can help by continuing your usual understanding. But in relation to the paperwork and maintaining training standards, our international partners can provide support by, I think, highlighting these issues with volunteers and seek advice from myself or from the program directors if things seem odd in relation to training standards. We do have new challenges which are related not only to the COVID situation, but also to the fact that we are emerging from this crisis with more developed training needs. In terms of the COVID-related challenges, we again have to address travel as we have the added challenge of health issues, quarantine and vaccination considerations and so on. We are making all efforts to be COVID-friendly, if there is such a thing, and COVID compliant, but international partners can provide support by just letting us know what you would like from us in this regard. We also have a challenge with the overseas training rotations, because during this time, there's been a significant decline in these rotations. We only had 3 this year. In 2019, we had 27. And this is a basic need. So we ask that you continue efforts to get back our training spaces with a view to actually increasing them. And I'll show you the need for this increase shortly. In terms of Zoom, We are using this forum bigly, as my residents say, but we have a limited number of accounts. So we asked if you could use your own when possible. And the different time zones can play havoc with scheduling. So please take this into account when scheduling in accordance with our academic times and be flexible. Because of staff shortages, we tend to have limited flexibility here at present. Another challenge with Zoom here is the increase in no-shows for many reasons, but it's internet connectivity issues. The resident has actually been redeployed because of the shortages, sometimes it's illness, and this affects us in terms of scheduling. So I'm wondering if maybe more pre-recorded lectures sent beforehand could be useful and used by volunteers to at least partly address this. A big challenge for us in the surgical and anesthesia specialties related to COVID is that our trainees are emerging with less or limited practical clinical experience. Now, I want to show you here where you can see the marked decrease in elective cases from pre-COVID compared to 2020, and it's basically the same now, though efforts have been made to restart electives. There was no change in the obstetrics as all the electives became emergencies anyway, so we didn't stop them. But for the other specialties, the skills gained during electives is gone. For instance, in gynae with elective hysterectomies, with surgery, just hernia repairs. And in anesthesia, a big one for us is airway management.
I'm still in both.
And this slide is just to emphasize that the number of emergencies did not change much, but it may not be the appropriate type for all trainee levels. And it's difficult to plan appropriate trainee experiences using emergency.
Is this like a YouTube video?
Experience alone.
Hi, I just want to ask everybody if they could make sure that their mic is paused. Just we're getting some feedback from somebody's mic. Thank you.
So because of the limited and less appropriate clinical experiences posed by COVID, I wonder if international partners can support us by increasing simulation efforts, maybe even using screen simulation, video links, and so on. In other words, help us to increase the use of technology in a clinical setting, just as we have recently done in the classroom via Zoom. We already have a camera system set up in our operating theater, in one of them at least, but need to explore the use of this more, I think. And in relation to our challenges, due to our more developed training needs, now we have more graduates, 26 more to be precise. In fact, we are emerging from COVID with 87 graduates in the surgical and anesthesia specialties compared to the 61 we had in 2019 BC. And we have added a new surgical specialty, ENT, that you see at the top here. And that was done with the help of a partnership in London, Ontario. So that now we have 70 residents in training in surgery, anesthesia, and obstetrics compared to the 55 that we had in 219 BC. More graduates mean we have more persons who can help with teaching and training, as well as having leadership and managerial roles in our programs. So international partners can help us in terms of faculty development and leadership training. And with more graduates, we also now have the luxury and the challenge of looking at career development and subspecialty training. And this is now a practical concern. So we ask that international partners, they can support us by offering fellowship training help. We prefer the model of doing as much as possible here in Guyana with the added necessary components by visits to your centers. So we would ask for a new type of volunteer to help with fellowship curriculum development and to teach and supervise in Guyana at this level. The final challenge I have here is related to our desire to be stronger in the research area. So I ask for your support in providing research supervisors and research mentors so we can develop in this area, as well as perhaps access to specialty journals. So overall, my view is that if we can keep on working together, we'll do as well as we did pre-COVID BC. For me, the partnership that really worked was because of good communication in its widest sense together with the ability to respond to each other's needs. We have had good partnerships here in Canada, and I truly hope this will continue as we settle in and try to overcome the new challenges posed during these abnormal, new normal times. Thank you.
Thanks very much, Dr. Harvey. We have about 5 minutes for question, and then we're going to go to our breakout rooms, but then there will be a chance for people to ask questions after that again. So I don't know, David, did you get any questions sent to you? I don't see anything in the chat.
No, sorry. I think if people have questions, they can also just unmute themselves and ask them.
Sure, that would be great.
Dr. Harvey, Jean Chamberlain here, obstetrics and gynecology at McMaster. I appreciate your point about the subspecialty training and the value that that brings. And I certainly, from my own personal experience of working abroad for many years, recognize how important it is for people to be trained in their own context. I wonder, though, when I think of subspecialty training, I think of Dr. Mike Kagawa, who's joined us here tonight, who's here at McMaster doing a one-year fellowship in maternal fetal medicine as a very experienced OBGYN from Uganda. I just wonder how feasible you feel it is to actually do a subspecialty training in your own center, when many times subspecialties actually require a lot more resources, specialized equipment, things that may not be available to the fellow if they were actually to try to train in their own country. What are your thoughts on?
Okay, thank you very much for your question. I agree. It could very well look like that there could be a major challenge, because indeed you're trying to train people with technology that we may not have so readily here. But we looked at this and we found that, well, it depended on the specialty area, and then each discipline would have a different length of time that maybe they would need to spend overseas. And it's actually worked in practice. We have one locally accredited fellowship, and that's in actually it's in in echocardiography, where the majority is being done here with the volunteers coming in and using technology and so on, so that even when they're not there, there's still the program can still go on and with supervision. And then the last about 3 months or so, the person would have to go to the center overseas, and that's actually in Canada at Calgary. And in anesthesia, we're looking at that same sort of module for next year in regional anesthesia, where the technology was actually brought in through our relationship with McMaster's with ultrasound machine, and then we were able to develop and get our own. And it's actually finding that it seems to be able to work, that the fellow could be doing their practice on the ground locally, and at some point, whether it's after 6 to 9 months, that then they would want to go and be in a center that where they could also be learning systems, as well as maybe refining techniques and so on. But we find that it can work. You have to choose your specialties. It's not all of them. I would appreciate that. But I say we have one, and we're looking for a second one that looks as if it's going to come on board. So I'm kind of hopeful. But I would agree, it's not across the board necessarily.
Great, thank you very much.
Alex, I think we have time.
Can I add something?
Oh, sure, Mike. Yeah, go ahead.
Yeah, thank you very much. And thank you, Dr. Harvey, for that presentation and
for that comment. I'm doing my fellowship in MFM, like I said, and I just wanted to echo what Dr. Harvey has said, that I think one of the challenges we sometimes have is limitations in terms of knowledge and skills, and probably not in equipment per se. Some of the equipment may actually be on the ground back home in our settings, but sometimes the skills to use these equipments. I can give an example, for example, just this mobile phone. It has so much that it can do, but just because you may be limited on how to use it, you only use the function of calling and receiving. So even in our settings, we have, for example, the ultrasound and some of these other equipment, but because we probably don't have the advanced skills that we may kind of learn when we come to places like McMaster, I sometimes think that we underutilize some of this equipment which we actually have on the ground. So I think this, these trainings can actually help skill us to go back and train. And definitely it would be much easier, for example, if 1 or 2 or 3 of us come here and then go back and train a bigger number of people than having kind of many people coming and staying longer from here than me, who probably comes and stays 1 year and then go back and stay for a longer time back home. Definitely, for example, you can't get someone from Canada to come and stay in Uganda for a very long time training, but it could be done the other way around. That's what I wanted to add.
Thanks, Mike, for that follow-up. I think before we move into breakout rooms, Dr. Cameron has a question, and if it's okay, David, I'd like to just address it before we do that. Dr. Cameron was asking, Dr. Harvey, if you could comment on the need for formal courses in research methods or even medical leadership that could be delivered locally in Guyana. Just wondering what your thought is about needs for that, or maybe something that's in process that you are already doing.
Okay, thanks, Dr. Cameron. Yes, indeed. You know, we have a great focus on developing our whole research portfolio and capabilities. As I had said, that you know, this is one of the things that our residents they have to produce a scholarly project in order to graduate. And we've been looking at different ways. What's been happening is that each program has been having their efforts to introduce, you know, research methods and so on. But more ideally, a research module. We reached where each program was having a research module. But basically, what we're looking at now is a research module that all the residents can take, and that's where we are. We've employed an epidemiologist and well, a biostatistician supposed to be developing a research module, but we're also making links with some others because there are modules there that can be taken by all residents where we want to go. So yes, there is a great need. We haven't quite filled it yet.
Yes, I have to unmute myself. Any further follow-up question at all, Dr. Cameron? All right then. I think David's going to move us into breakout rooms, and we will go to a breakout room for about 10 minutes, and then we will all reconvene again after that.
Okay, well, great. Well, thanks everybody. Thanks for coming back, and I hope you had a good session there. With I know we certainly had a very engaging conversation going on. So, and just in the interest of time, we are not going to continue for too much longer, but just wanted to thank everybody for coming this evening, and just really thank everybody for their participation and just the examples that they've given as well too. I know we were just at the end of our conversation talking about Dr. Ellett's example of, sort of at the end of her career now, spending 5 years being engaged in teaching, and just really the need for those kinds of individuals to be involved. And that's what really makes these kind of partnerships work, is the long-term relationships and work. So thanks to everybody for your examples. And just a reminder that if you do have any other questions that you wanted to ask, please send them to that email that David put on the chat there. And we're more than happy to, maybe Dr. Okong or Dr. Harvey, Dr. Ellett can answer your questions. Happy to do that. Also, make sure that you do check out the MacGLObAS website as well too. Join the group there, so you make sure that you get information about upcoming events. There's a newsletter, etc. Please share it with other people. We really want to invite others to be part of it, and that's what builds a multidisciplinary group, is by getting more people involved than just sort of those of us that that might even be here tonight. So please make sure that you share that with others that might be interested. Also, David is going to be sending around an evaluation, and if you could just take a minute of your time to fill that out, would be really, really helpful. We're looking for information on how people found this evening. Is there ways we could do things differently, timing, all those sorts of things, just giving your feedback. It won't take you much time, but if you could take a few moments to do that, we would be really, really grateful. So if there's anything else that anybody else wanted to put, I don't see anything in the chat, except there is a question here for Dr. Ellett. So maybe if she's still, Dr. Ellett's still on. Yes, she is. Dr. Ellett, seen a program in LIC in low-income countries where using cryosurgery for cervical cancer. That's a question that's come into you, Dr. Ellett.
So the treatment for cervical cancer is usually radical surgery or radical chemoradiation. But in the scenario of pre-cancer, cryotherapy is probably one of the oldest technologies, and actually fairly easy to implement, especially if you have a pot bottling opportunity in your country, because that's where the gas comes for the cryotherapy. There is a transition happening that's probably a safer and easier to use technology called thermocoagulation. So in those settings where either by visual inspection with acetic acid or pap smear or HPV testing, you find that the patient has pre-cervix cancer cells that are abnormal, thermocoagulation is probably becoming the standard in the low resource setting, applied usually by nurses.
Great. Thank you very much, Dr. Wood, there for your question as well. And we say hello to you as well. Like someone who's had lots of experience in training and teaching and partnerships there in the Congo. So thank you so much, Dr. Wood, for that question. So if there's nothing else that's come up in the chat, I don't want to continue speaking any longer, but I just really do want to thank everybody for participating. It was great to have you, each one of you. Dr. Harvey, thank you so much for joining us and all the challenges of your day. And at the end of the day, to spend this time with us, we're really, really grateful. And Dr. Ellett, we wish you the best as you fly off tomorrow. And we will send our greetings to Dr. Okong as well, too, for joining us virtually as well today. So thanks to everybody. Look forward to meeting with you again with the next sessions. And again, a special shout out and thanks to Dave and to each one of you. So have a great night, and thanks for joining us tonight as we remember the storm and remember the beauty in the storm and how it's helping us to think differently wherever we are. So good night, everybody. Have a good evening. Thanks. Bye-bye.